Okay, so today we get to learn how to master the art of sleep. Claire Edwins is here with us, and Claire is an advanced registered nurse practitioner who specializes in sleep medicine, and she is here to share important information um, to help us know how to improve our quality of sleep, what issues that arise as we age that can create challenges to good sleep. So I want to welcome Claire to Intentional Aging. I will stop sharing and turn it all over to you, Claire. Welcome and thank you for being here.
Thank you so much, Karina. Hi, everyone. I'm Claire. Like Karina was saying, I'm a nurse practitioner here with Olympic Medical. I've been in this role now with our sleep medicine practice for about 2 years. And it's such a fascinating specialty. I feel like I'm always learning something new. So I'm really excited to share with you guys today. I'm going to go ahead and share my screen and get the PowerPoint pulled up here. Let's see. All right. Is everyone able to see my presentation and hear me okay? Great. All right. So before we get started, I do want to take just a moment to emphasize the importance of gerontological concerns. The future is old. The World Health Organization anticipates by the year 2030 that 1 in 6 people will be aged 60 or older. So as a community, especially as a healthcare professional, the concerns of older adults are the concerns of everybody. We need to be sure that we are thinking about those concerns into older age so that we can maintain the dignity and the health and the quality of life for our aging population. I want to start our conversation off today with the yin yang. As you probably know, in Chinese philosophy, yin yang represents a complementary duality, opposites that exist together in a state of balance. Don't worry, we're not going to get too philosophical or new age. I think the yin yang is a really great representation of the duality and the balance between sleep and wake. In fact, it used to be the American Academy of Sleep Medicine's old logo. Sleep and wake complement each other. The things that we do in the daytime impact our sleep at night, and sleep enables us to be awake, to be engaged in our life, to enjoy our life, and to be healthy while we're awake. You really can't pull the two apart. Now, everybody knows how they feel after they get a poor night's sleep. It makes it really hard to get through the day. And that's because we know that sleep is really important for our health. It impacts every aspect of our health. In medicine, we don't quite understand exactly what happens during sleep or exactly why we sleep, but there has been a lot of research on sleep deprivation. And through this research, we understand the many impacts that sleep has. Insufficient sleep has detrimental effects on every aspect, right? We see detrimental effects from insufficient sleep on cognitive performance, on our ability to pay attention and to react to things. Those skills that we need to be safe, for example, when we're driving in a car. Poor sleep quality impacts our memory, our ability to learn. It impacts our higher level cognitive functioning, such as problem solving and creativity. Poor sleep impacts our mood. We're more likely to experience symptoms of depression and anxiety if we have insufficient sleep. And insufficient sleep impacts the mind as well as the body. Insufficient sleep is associated with cardiovascular disease, hypertension, cardiac arrest, greater incidence of plaque in our arteries. Insufficient sleep is also associated with detrimental effects to our metabolism. It's associated with obesity and high blood sugar. We see a correlation between insufficient sleep and higher levels of inflammation in our body, as well as a poor immune system function with insufficient sleep. The American Academy of Sleep Medicine has since changed their logo. I think it's very nice, very classy. I'm not an artist, I'm not a graphic designer, but if I was designing their logo, I would start with something like this: 3 parts of a whole. The lower third representing sleep, because adults spend about a third of their life sleeping. 1/3 of 24 hours would be 8 hours. Who here got 8 hours of sleep last night? Not everybody, right? Some people get more, some people get less. So when we think about norms, we have to take that with a grain of salt, right? It's really hard to distill almost 8 billion people into a single number. And we think about how we do research to find norms. Was that research done on someone your age, someone your gender, someone that looks like you and is from your background? So I don't want you to panic if you're not getting exactly 8 hours of sleep every night. While we do take those norms with a grain of salt, there are things that we can expect to see with normal sleep. So let's start talking about some of those things. Normal sleep in humans is driven by 2 processes, and those processes are represented by the graph here in the top right corner: process C and process S. Process C is our circadian rhythm. Humans have evolved to be awake when it's daylight and to sleep when it's nighttime. The other process that controls our sleep is process S, which is the homeostatic drive for sleep. In medicine, homeostasis is a fancy word that we use to say balance. Process S, or that homeostatic drive, represents how sleepy you feel. The longer that we're awake, the greater our need for sleep. And the longer we sleep, the more able we are to be awake. We also anticipate to see some normal changes in the brain when we sleep. When we measure sleep at our sleep labs, we're looking at the electrical activity of your brain, the movement of your eyes, and the muscle tone of your chin. Normal sleep occurs in a little bit of a pattern with that electrical activity of the brain. We have 2 types of sleep: non-REM and REM sleep. Non-REM is non-rapid eye movement sleep, and REM sleep is rapid eye movement sleep. So as adults, we enter our sleep through non-rapid eye movement, non-REM stage 1, which is that transition from wake into sleep. And as we continue to sleep, we move into non-REM stages 2 and 3, deeper and deeper into sleep as our brain activity slows down. Non-REM stage 3 is the deepest sleep that we get. And then we tend to see a little bit of a lightening back into non-REM stage 2 before we enter our first cycle of REM sleep. REM sleep, when we have rapid eye movement, what we see in someone's brain is that it's very active. That's when we're dreaming the most. Our eyes are moving and our diaphragm is moving to keep us breathing, but all of our other muscles in our body are completely relaxed. That cycle then repeats: non-REM stages 2 and 3, back into 2 and in REM sleep, over and over again throughout the night for about 2 to 5 cycles. There are some changes, some normal changes that we can expect to see with aging. With aging, we see some changes to our cellular and molecular activity. A little bit of damage that occurs to that activity, and we see some changes to our sleep. So it is normal in older age to experience a decrease to our total sleep time. We don't sleep as much as we may have used to, especially compared to when we were in our early 20s and teens and when we were children. We can anticipate to see more frequent nocturnal awakenings, waking up in the middle of the night and remembering those awakenings, being awake for a little bit longer than we may have in the past. We see, because of that, a decrease in our sleep efficiency. The ratio of time we spend in bed compared to the ratio of the time we spend asleep decreases. We do see a decrease in the slow wave sleep, that stage non-REM stage 3, sometimes a little bit of a decrease in REM sleep, and therefore an increase in those lighter stages of sleep, non-REM stages 1 and 2. We see an increase in the frequency of daytime napping in older adults, and we tend to see an advanced sleep phase that older adults go to sleep earlier and wake up earlier than they may have in the past. One good thing to know about these changes is that they tend to stabilize around age 60. We spoke a little bit about the interplay between sleep and wake. So these are changes that we expect to see in older adults during sleep. What about changes that we expect to see in an older adult's health during wake? Well, with that change to our cellular biology, we do tend to see an increased incidence of chronic disease in older adults and increased use of medication. Those things can impact our sleep at night. And there's a concept that we call geriatric syndromes, conditions that can affect older adults. Some of these things would be mobility issues, urinary issues, cognitive issues, depression and pain can occur with older age, and functional decline, maybe needing a little bit more help with things that we haven't in the past, even something like wearing hearing aids or glasses. These things can impact our sleep because they impact our daily life. For example, if you have lower back pain that's uncontrolled, that makes it harder to be mobile, and you're more sedentary in the daytime, it can sometimes be harder to sleep at night. If you take away anything from our conversation today, it is that it is so important to have someone that you can trust, that's a healthcare professional, that you can talk to about any of your concerns with daytime or nighttime symptoms, or even just go to for medical advice. You know, traditionally, that is the role of the primary care provider. So it's very important to have that person, that professional that you can go to, because we want to make sure that we're our healthiest in the daytime, that any kind of daytime symptom that you're having that may bleed over into your sleep is adequately addressed so that you can get the best quality of sleep. So we're talking about things we anticipate to be normal with our sleep and in older age. What about what's abnormal? We can do everything right to get the best quality of sleep at night possible. But if we have an underlying sleep disorder, we're kind of set up to fail unless that sleep disorder gets addressed. So I do want to touch base with you guys and go over a few common sleep disorders that can occur in older age. We'll start off talking about obstructive sleep apnea. OSA is a condition that impacts our breathing during sleep. It makes it harder to breathe while we're asleep. And when we're talking about OSA, our focus is really on the upper airway, the passageway that air takes through the nose and the mouth into the back of the throat before it gets to our windpipe to go down to our lungs. In obstructive sleep apnea, when we're laying down and our muscles are relaxed, this passageway gets blocked off. Essentially, it's like you're trying to breathe through kinked plumbing. It doesn't work very well. So it's harder to get good oxygen down to our lungs when we're struggling to breathe, and it's harder to get a good quality of sleep because our brain and our body is more alert than it should be, trying to get that air down to the lungs throughout the night. Risk factors for obstructive sleep apnea include older age, being a male, although women do kind of catch up to men after menopause. Neck circumference is another risk factor, so having excess weight puts you at a greater risk for sleep apnea. We do see some genetic risks, so family history, just the way that that part of your upper body is structured. And alcohol can increase the incidence of obstructive sleep apnea. Anything that relaxes our muscles more puts us at a greater risk. If you are experiencing obstructive sleep apnea, you will have probably been told that you snore loudly at night. You may wake up from your sleep gasping or choking, trying to get that air into the lungs. Or you may wake up and not really realize why, but frequent awakenings throughout the night are very common. If you have a bed partner, someone in the bed with you, your spouse, a significant other, they may have noticed pauses in your breathing as you're struggling to get that air into the lungs. And that can be really concerning for our partners when we hear someone we love stop breathing. Or you may have heard from an anesthesiologist. Recovery from surgery is a risky time for obstructive sleep apnea because we are usually positioned on our back with gravity pulling all that soft tissue back into the throat, and we've been sedated. So we do get a lot of referrals, for example, after colonoscopies. People who have obstructive sleep apnea often will sleep for a regular amount of time, 7, 8, 9, 10 hours, but they will wake up feeling as though they haven't slept well at all because they're not. So non-restorative sleep and excessive daytime sleepiness, having difficulty getting through the day are really common. If you aren't oxygenating well at night, you may wake up with a headache. We also can see dry or sore throat in the morning, and just difficulty getting through the day, low mood, and impaired cognition and concentration. Obstructive sleep apnea is very easily treated with positive airway pressure, a CPAP machine that gives gentle air pressure into that upper airway to splint it open and prevent it from collapsing. It can also be treated with oral appliance that pulls the lower jaw forward, keeping the tongue from sliding back and blocking the airway. And there are some surgical interventions that can help with obstructive sleep apnea as well. Restless leg syndrome is another common sleep disorder that can make it harder to fall asleep at night. Restless leg syndrome is characteristically hard to describe for people. You might notice when you sit down, maybe to watch TV or when you get into bed, that there are uncomfortable sensations in your legs. It might feel like aching or burning, tingling, a creepy crawling feeling, but you have this urge to move the legs. And when you move the legs, that helps, that relieves those symptoms, but only while you're moving. When you stop moving, those symptoms come back. If those limb movements persist during sleep, you might hear from your bed partner or spouse that you've been kicking in the night. And you might notice too, when you wake up in the morning, that the sheets are all askew, or that you've even worn a hole in the sheets from moving throughout the night. Restless leg syndrome can also impact our arms. So that's another syndrome that can really make it hard to get that quality sleep. We see, again, genetic risks with family history. Restless leg syndrome can occur when we have low iron levels, particularly low storage of iron in the brain, a low ferritin level. It can occur with certain medications and other health issues such as Parkinsonism, end-stage renal disease, peripheral neuropathy, peripheral artery disease, and it's pretty common in pregnancy as well. And then stimulants, nicotine and caffeine, as well as alcohol, can worsen symptoms of restless leg syndrome. Treatment includes avoiding those triggers if there are medications that you're taking, or if you do use a lot of stimulants, trying to get away from some of those things, testing the iron and ferritin levels, and then there are some medications that can help with restless leg syndrome as well. Another very interesting and less well-known sleep disorder is what we call REM sleep behavior disorder. When we were discussing those stages of sleep earlier, REM sleep, we see more active brain activity, we see more dreaming, but it's very typical that we have muscle atonia during REM sleep, a complete lack of muscle tone. Even sitting here right now while we're relaxed, we have some muscle tone, but in normal REM sleep, it's almost like you're paralyzed. If you lose that muscle atonia, you can actually move around while you're dreaming. And that's the number one key characteristic of this REM sleep behavior disorder, acting our dreams out physically. Some people do vocalize during their dreams, maybe screaming, yelling, talking, and it's typically pretty coherent what people are saying. These dreams that we act out, they tend to be scary dreams, dreams of persecution, dreams of being attacked, or dreams of pursuit. So it's not uncommon that people will kind of fight in their dreams. Sometimes they might even, unbeknownst to them, reach out and hit their spouse. So it can be something that's difficult for people to talk about, something that people can feel a little bit of shame about, but it's something that we worry about in terms of safety. We want to make sure that everyone is safe at night, whether it's you and or your bed partner. Because these symptoms are associated with REM sleep, we can expect to see them occurring more toward the end of the sleep, the early morning hours, when we have more frequent and longer periods of REM sleep. And typically people do remember the situation in their dream upon waking. Risk factors, again, older age. There's a big overlap with REM sleep behavior disorder and neurodegenerative disease like Parkinson's and Lewy body dementia. Some medications can cause these behaviors, as can some psychiatric disorders like PTSD. We treat REM sleep behavior disorder by, first of all, maintaining a safe environment, ensuring there's nothing sharp or breakable at the bedside, no tripping hazards in the bedroom, were you to get up out of bed. It's very important to sleep alone, whether that means sleeping with your spouse in 2 beds in the same room or sleeping in a room by yourself. It's also important that if you are experiencing symptoms like this, that if you do own a weapon like a gun, that you keep it safe, secured, stored outside of the bedroom. We also have everyone's least favorite sleep disorder of insomnia. When we're talking about insomnia, I think it's really important to differentiate short-term versus chronic insomnia. I'm sure everyone here has suffered from that short-term insomnia when we're worried about a problem at work or there's a loss of a family member. That typically lasts for a couple of weeks. And then chronic insomnia is difficulty sleeping that persists months or even years. It's also important to differentiate the difference between sleep onset versus sleep maintenance insomnia. Sleep onset insomnia is difficulty falling asleep, whereas sleep maintenance insomnia is difficulty staying asleep. And you can have both together as well. Risk factors for insomnia, we definitely want to rule out other sleep disorders like obstructive sleep apnea or restless leg syndrome that could be causing some of the difficulty staying asleep. We can see more insomnia with older age. There are some genetic risk factors. It does tend to run in families. Having a history of shift work where maybe you had to stay up all night can impact our circadian rhythm and make it harder to sleep at night. Life stressors, of course, can lead to insomnia. Lifestyle factors like being sedentary in the daytime, and again, caffeine, nicotine, and alcohol use. Oftentimes, people find that alcohol does make them drowsy. It might make it a little easier to get to sleep, but what it gives you in terms of sleep onset, it takes away in terms of sleep maintenance. Alcohol does not mix well with sleep, and it tends to lead to more awakenings throughout the night, more bathroom trips throughout the night, and it can really make it harder to get back to sleep after those awakenings. Insomnia, particularly short-term insomnia, can be treated with medications. But when we look at research that's been done on insomnia, the treatment that we have the most evidence for being effective in the long term is actually called cognitive behavioral therapy for insomnia. Really trying to shift your attitude and your behaviors around sleep. Again, we're going to touch back on that importance of having a healthcare professional that you trust. If you or someone that you care about is experiencing symptoms of a sleep disorder, it's so important to get those addressed because you're not going to improve your sleep if you have something that's going on disrupting that. And these things can have wide-ranging effects, not just on our sleep, but in our waking lives as well. So you've gone to your doctor, you've addressed all your concerns about sleep and wake. What do we do to improve our sleep now, to improve our sleep at home, to improve our sleep on our own? If you want to take action, what do we do that works? Well, I hate to tell you, I don't have anything that's really groundbreaking. Probably a lot of things that you've already heard before. The number one most important thing you can do to help improve your sleep is to really adhere to a consistent sleep schedule. The key to setting your schedule is to get up at the same time every single morning, regardless of the day of the week. You might have to have somebody grab you by your ankles and pull you out of bed, but it is easier to set the time to wake up than it is to set the time to fall asleep. So you pick whatever time works for you. So maybe that's 8 in the morning. And then you work backwards from there to set your bedtime. You want to try to think about how much sleep you usually get, and that's going to be different for everybody. You want to allow for at least 6 or 7 hours, but again, trying to match your amount of sleep to the average amount that you typically get. Let's say that's 7 hours. So 8 a.m. minus 7 would be 1 a.m. So you want to think, okay, I'm going to be in my bed, eyes closed, asleep by 1. You also want to think about naps. Ideally, avoiding naps can make it easier to sleep at night, but there's nothing inherently wrong about taking a nap. You just want to schedule those as well. I know scheduling isn't fun. One of the benefits of being retired is that you don't have to adhere to a schedule, but scheduling your nap makes it less likely that you're going to doze off unintentionally at other times. If we sleep too close to bedtime or for too long in the daytime, it can interrupt that homeostatic drive for sleep. We don't have as great of a need for sleep at bedtime anymore. So you've got your schedule, 1 to 8. The next thing you want to think about is your environment, your bedroom. You want your bedroom to be quiet, dark, cool, and comfortable. And again, this is going to be personal for everybody, but really trying to make sure that your bedroom is a haven. We sleep better when it's dark, but you might need a nightlight if you want to get up safely to the bathroom in the night. People do tend to sleep better alone, although it can be comforting to have pets and people in the room. But if you notice that those things are disturbing you, consider trying to sleep alone, or even using maybe white noise to muffle out any other sounds in the environment. You also want to kind of restrict the use of the bed and the bedroom only for sleep or for sex. You want to create a subconscious association between your brain and the bed as the place for sleep. So that means not watching TV in the bed and getting up promptly after waking. So you've got your schedule, your bedroom's nice and comfortable. It's 8 a.m., you just got out of bed, you're ready to start your day. We want to kind of think back to that circadian rhythm, daylight. Getting bright light and natural light exposure in the morning can be really helpful to tell our body, hey, it's time to get up, time to be alert, time to get the day going. If you can get outside or have your breakfast, your morning cup of coffee in a bright sunny part of the house, that's going to help to strengthen your circadian rhythm. It's very important to be physically and mentally active in the daytime. I'm sure you've experienced those days where you're just going all day and you sleep great. So trying, even if it's just 10 minutes, to get into a good routine of physical activity. It can also be really helpful if there are things on your mind to address those worries in the daytime so that they're less likely to bother you when you lay down to go to sleep at nighttime. You know, if you are remodeling your kitchen and you have the plumber coming and you need to call them, you know, make a to-do list so you can put those worries aside before bed. It's also important to limit caffeine in the afternoon. Caffeine stays in our system for a really long time, particularly with aging, as we might not process caffeine or other drugs as quickly as we have in the past. So you've gone through your day, the day's winding down, you're getting ready to sit down and relax in the evening. And the opposite is true in the evening with regard to light. You want to try to limit that light exposure. Our brain sees that bright light, whether it's coming in through the window, the overhead lights, or the computer, TV, and cell phone as daylight. And that reduces the body's production of melatonin in the evening. So getting away from the electronics at least 30 minutes before we go to bed can help our body make that melatonin as it should. It's helpful to avoid having a large meal close to bedtime, to avoid alcohol close to bedtime, and to consider kind of reducing your fluid intake toward the evening hours, or trying to front load your fluid intake in the daytime so you're less likely to have to get up to go to the bathroom at night. It's really good to kind of establish a nice bedtime routine, some set things that you typically do before bed that can help you to relax and to get into that sleep mode. Maybe you put on your comfortable pajamas, brush your teeth, do a devotional, tuck your spouse in, and then you're ready to get into your bed. We don't want to go to bed until we're sleepy. A lot of times people will struggle with sleep and they'll spend more and more time in bed. But if you only need 7 hours of sleep and you're in bed for 10 hours, that's 3 hours that you're going to be laying there tossing and turning, feeling frustrated. So do be cognizant of that bedtime that you set, but there's no point in getting into bed until you're actually sleepy. It can be helpful to also practice mind-body relaxation techniques, particularly if your mind tends to race in the evening. This would be things like meditation or deep breathing, progressive relaxation, where your focus is on your body rather than letting the mind wander. So you've tucked your spouse in, you're in bed, and you're not falling asleep. You're laying there, you're tossing and turning, you're frustrated. What should you do? Don't stay in bed. This can be frustrating, but it's helpful actually to get up out of bed, go into the other room, get that book that you only read when you're struggling to sleep, sit down and remind yourself, this is okay, this has happened before, this is going to happen again. I'm just going to read a little bit until you get drowsy and then return to bed. It's really hard not to watch the clock at night, but it's not helpful to watch the clock at night. As soon as we look at the time, we start thinking about how much we may have slept, how much sleep we can still get, and everything that we have to do the next day. So try not to watch the clock, try to cover it up if you need to. And you may have to get up a couple of times if you're waking up in the night, but don't get frustrated. 8 a.m. rolls around, you're going to get up anyway. Go through your daily routine and have confidence to know that you'll sleep better tonight, even if you didn't sleep that well the night previously. Our body wants that regular schedule. That's that circadian rhythm. And really just building those habits is the best thing that we can do to improve our sleep overall. You might be thinking, she didn't say anything about medication. What about drugs? What about sleeping pills? I have to admit, I'm a little bit conservative when it comes to medication because every medication has side effects, even Tylenol. There is a time and a place for medications, like in the treatment of restless leg syndrome or REM sleep behavior disorder. And medications can be helpful with short-term insomnia. When we look at the American Academy of Sleep Medicine's recommendations for the pharmacological treatment of sleep issues, what we get is actually 14 weak recommendations, either for or against the use of drugs. What does this mean? What is a weak recommendation? That means that there is not a lot of research that supports the use of any of these medications for efficacious or safe treatment. And actually, 7 of these 14 drugs, we recommend caution in older adults. That's because sleeping pills make you sleepy, they make you drowsy. Certain sleeping medications can even be a little bit habit forming or hard to stop if we've been taking them for a long time. Anything that sedates you puts you at a greater risk of accidents or injuries. And a lot of people will take medication to help them sleep that makes them feel groggy in the morning. And what's the point to that, right? If your sleep is not refreshing. The doxapen and the diphenhydramine on this list, which is Benadryl, have strong anticholinergic properties. Some side effects that we can expect to see with those medications. Those side effects can be summarized as can't see, can't pee, can't spit, can't defecate. So they can cause dry eyes, urinary retention, constipation, dry mouth, and there is some research that shows long-term use of Benadryl is associated with cognitive impairment in older adults. So just because you can get something over the counter doesn't mean that it's safe to take. And interestingly, I think the 12th recommendation on our list, melatonin, the American Academy of Sleep Medicine has a weak recommendation that we not use melatonin to help us sleep because the benefits are so marginal in terms of total sleep time and sleep onset. There are also some medications that are often given off-label to help people sleep that can be a little more risky in an older population. And again, I'm not saying there's no place for medication, but circling back, it's so important to have a primary care physician or someone that you trust that you can talk to before you take any medication, whether it's a prescription or it's something over the counter. You want to be cognizant of the side effects to look for. You want to be sure that there's not interactions with the other medications that you're taking. You want to know how to take it, when to take it, and how to stop taking it if you do want to stop in the future. If there's been anything that you take away, again, I think it's really important to have a good relationship with someone that you can trust and go to for medical advice. And if there's been anything that kind of brought up a red flag in your mind, whether that's a concern about your health in the daytime that's impacting your sleep, or symptoms of a sleep disorder that sound like something you may be experiencing or a loved one may be experiencing, I encourage you to take action. When we're talking about those things that we can do to improve our sleep in general, make a list, get a piece of paper and a pen and write down a plan for yourself, make that schedule. Think about things that you can change. Behavioral change is really hard, and I'm not saying that you should turn your whole life upside down in one night, but focusing on a few things that you might be able to make a difference with and putting that plan into action. Nothing will change in our lives unless we do something to make it change. So I do encourage you to take action if you feel compelled to do so. I compiled, of course, my references for today's discussion, as well as some references that you might be interested to look for at the library. There are a lot of books. These are some that I checked out and looked into myself that seem pretty quality, that are available within the system. And I'd like to just kind of open up our discussion to see if anybody has questions, comments, stories about things that they may have experienced, whether that be with sleep difficulty, medications, or anybody that uses CPAP. Yeah. Let's see.
I do see in the chat, Claire, that Wendy asked if you could repeat what you shared about Benadryl.
Absolutely, yeah. So Benadryl is the class of medication is a first-generation antihistamine. The other name for Benadryl is diphenhydramine, and it's very commonly used in over-the-counter medications, over-the-counter sleeping pills. The reason that Benadryl works to make us sleepy is because it crosses the blood-brain barrier. So some of that medication actually goes to the brain and it can be sedating. These medications are not necessarily safe. Just because you can buy it at Costco doesn't mean it's a good medication to take. These medications tend to have really common side effects. We call them anticholinergic side effects. Those side effects can be dry mouth, dry eyes, constipation, and urinary retention. And I've always thought urinary retention sounds great for sleep, right? Maybe I won't have to get up and go to the bathroom. But that's not actually what urinary retention means. It means you're still going to get up to go to the bathroom, but you're not going to empty the tank. You're going to have to get up half an hour later and then go to the bathroom again. So those medications can have a lot of nasty side effects. And there is some research on Benadryl that suggests that long-term use, long-term chronic use of Benadryl is associated with cognitive difficulties. You're welcome.
Hey, I have a comment.
Yes.
You know, something I picked up that I use to go to sleep. My wife does it infrequently, but I do it every night. It's called, and I'm sure you've all seen it. It's the 4-7-8 system.
Yeah, tell us more about that, Rob.
The 4 is you take 4 deep breaths and hold it, and then you count to, I go 1001, 1002 to 1007, holding my breath. And then once I get to 7, I go again a recount to 1001 to 8, blowing out slowly the air. And I do that 4 times. And when I'm done, I roll on my side, and I don't know when, but seconds later, I'm asleep.
Yeah, that's wonderful.
And I've been doing it for over a year now.
Yeah, I think that's a great strategy. And we actually can see when someone is meditating, for example, similar brain activity as to when they are falling asleep in that first lightest stage of sleep. So those activities, those meditative activities or deep breathing exercises, they calm our brain and they quiet our mind and they give us something to focus on that's relaxing rather than thinking about everything that we have to do today or something that you said 3 weeks ago. So I think that's a wonderful strategy.
You know, I get up, my wife and I get up about 4 o'clock in the morning, and we wear headlights, so don't worry about us. We go out and walk in the morning, and we see all the deer then. And so when I come back about 7 o'clock, I usually take about an hour's nap.
Mhm.
But I found that in taking that hour's nap, I do what you're saying. I have this comforting blanket on the couch. I raise it over my head, but I do my 4, 7, 8, and I go right to sleep.
Yeah, that's
Even
really
for a nap.
I see that Amy asked a question about pets and aligning their schedule to your sleep schedule. That's a really great comment, Amy. I hear a lot of times that cats and dogs will want to be fed at a particular time, and that people kind of structure their sleep around their animals' needs. I don't know that I have a really great solution for that in terms of kind of training the animal. I don't know if it's possible. I'm sure it might be. And that can be a barrier, like changing the animal's routine can be a barrier. For example, getting animals out of the bedroom can sometimes cause more disruption at first, but it's definitely worth trying because, you know, nobody wants to get up at 4 o'clock and, you know, pour the cat food and then get back in bed. So I would definitely maybe look into like animal training resources in the community or books. I know sometimes cats in particular can like feed themselves with a little pet dispenser, or if dogs and cats need to go out, you know, getting a doggy door if you have a fenced yard. If it's not something that you can change with the pet schedule, really giving that some thought when you're creating your schedule. You know, if you know that you're going to be up at 5 a.m. and you want to get your 7 hours, that's going to make your bedtime earlier. If you do need to get back in bed after waking up in the morning, that is a good time to get a little bit more sleep or take a nap in terms of scheduling that nap time or that rest time in the day. You just really want to try to avoid napping or dozing while you're watching TV or at 6 p.m. if your ideal bedtime is 10. But pets can be a great motivator for exercise. You know, knowing that that dog or cat wants to get out and go for a walk can help us to get out and go for a walk. Let's see, Cindy, I see you have a question as well.
Yeah, I just wanted to comment that I also had some sleep issues when I was younger, and I was getting about 4, maybe 5 hours of sleep a night, and I thought it was something physical, and it turns out it was my bad habits. And I went to a sleep clinic, and what they told me, and I've shared this with a lot of other people, the fact that you want to, you know, kind of hit the pillow and go to bed, go to sleep and stay asleep. And so for about 2 weeks, working with the sleep clinic, I was kind of what they call a sleep diet. And it was determining, you know, how much sleep are you getting now? And you need to get up, like, just like you said, get up at the same time every day. So you set your alarm, cover the clock so you don't see what it is. Their thing was you go to bed, but what you do is you figure out, okay, so maybe I'm going to bed and sleeping only for 4 hours and I need to get up at 8. So I go to bed at 4 in the morning then that first day. And it was to force myself to be so tired that when my head hit the pillow, I would be asleep. And then once you do that, you back it up so that, the next night it's 5 hours. And the whole thing was, if you're not falling asleep, you feel like you're not falling asleep within 15 minutes, like you said, get up, get out of bed, read, don't do anything that kind of excites you. But when you start to feel sleepy, go back to bed. And the whole point was to back it up enough that you are hitting the pillow, and within 15 minutes and 30 minutes, you're asleep and you stay asleep. And that really cured me of a lot of the bad habits I had acquired over the years. And I still do that. If I try not to look at the clock at night. I set the alarm so I know I'm not going to oversleep. But then assume, and know that you are going to get enough sleep. If you didn't get it one night, you're going to get it the next or the next. And that just, I have this whole list of things that happened during the sleep clinic, this sleep diet. And I've shared it with a lot of people, and it's all the things you talked about. But I think the emphasis was, don't be afraid that you're not going to get enough sleep, because you will. Your body will force you to go to sleep, and get that.
Absolutely. Thank you so much for sharing that, Cindy. And I'm so glad that that was successful for you. What you're describing, it sounds like that cognitive behavioral therapy for insomnia, really trying to change your routine and changing your attitude is a big part of that, because insomnia is so stressful and frustrating, and we can develop kind of an expectation that we're going to sleep poorly, and that can be a self-fulfilling prophecy. When you are changing your schedule, you're describing to me what sounds like a little bit of sleep restriction, trying to shorten that window. And that can be really helpful, like you're saying, so that you are going to fall asleep when your bed hits the pillow, and then moving that bedtime earlier by small increments until you find your unique need for sleep, because not everybody needs that 8 hours. So trying to determine what your needs are. Certainly I wouldn't want anyone to restrict their sleep less than 6 hours without, help from a healthcare professional. But those strategies that you're describing are exactly what we do for, evidence supported medicine. Those cognitive behavioral strategies are what do work in the long term, but it's hard, and it sometimes makes the problem a little bit worse before it gets better. Is there anyone here who has had a sleep study in a lab?
Hi, I'm Laura.
Yes.
I had it, it's been several years. I had it and I didn't qualify for a CPAP machine. So, but it was hard to sleep with all the stuff on your head. But I mean, it's like, oh yeah, I never go to sleep. But I'm glad. I was gonna ask you, should people have that done periodically, like every 5 years or something? Or I know I've got usually have a stuffy nose, and that might make me snore, but I don't sleep with anybody anymore.
Yeah. So we often do sleep studies in the lab to look for those sleep disorders like obstructive sleep apnea and restless legs. The sleep study is the definitive gold standard test for understanding what's happening during your sleep. It involves going into a laboratory overnight, and you're right, Laura, it's weird. It's a lot of equipment that we put on you. Like we mentioned earlier, we're looking at your brain activity. So we've got equipment on your head. We're looking at your eye movements. There's equipment on your face. There's equipment on your chest, on your arms and your legs. But we get a really comprehensive understanding of what's happening when you're asleep, when you're waking up, if you're breathing well, if your limbs are moving a lot, and if there is any kind of impact on the cardiovascular system. Indications for sleep studies, sometimes we do repeat sleep studies if your symptoms change. If you don't have sleep apnea 5 years ago, it doesn't mean that you don't have it today. Risk does increase as we lose muscle tone with age, and risk increases if we gain weight and there's more tissue in our neck that compresses the airway. Our health can change in many ways. Sometimes we see changes to the breathing that are associated with stroke or heart disease as well. So sometimes we do need to get a repeat sleep study. And I know we just talked about how weird and strange and cumbersome it can be, but there is also a home sleep test that can be done, particularly to screen for sleep apnea. I see we've got some CPAP users here. Yeah. I love to see that. Yeah, CPAP can be intimidating, but if you need it, it helps you. Is there anyone that would be interested to share their experience? You know, what led up to getting their CPAP, or how the CPAP might have changed their quality of sleep?
I can talk a little bit about that. It was 6 years or so ago. I think I was talking to a PCP about, I didn't feel like I was getting, enough sleep, or I didn't feel right about my sleep or something like that. And so they prescribed me a sleep study, and the sleep study definitely showed that, I needed a CPAP machine. And I come see you once a year. And right now, my current PCP has got me deliberately drinking 60 fluid ounces of water a day. Or, well, not water. I can't drink, just water. And so that's been making me get up in the middle of the night. I try and keep it, towards the beginning of the day, but it just doesn't work. I've got too many pills to eat at night, and it's up at least once in the middle of the night. So I will figure this out, and I'm supposed to do this for like 2 or 3 months, and then go get the kidney blood test again to see if that's helped. And if not, then we'll go somewhere else.
Yeah, I appreciate you sharing that, Evelyn. And you make a great point. You know, life gets in the way, and you can't always do everything that's on a list of paper, right?
Right.
We have to work within the constraints of our health conditions and our therapies and our lifestyles. Just trying to come up with the best plan that we can to really try to preserve our sleep as much as possible. Do you recall when you first got your CPAP, was it easy to get used to? Was it hard to get used to? How did you overcome that difficulty kind of adapting to therapy?
I don't think I had too much difficulty adapting to therapy. There's a strange thing though. Recently I've noticed that when I get up at the end of the, when I get up, not in the middle of the night thing, you have to take the thing off, but when I get up at the end of my sleep period, I actually have to, I seem like I have to mentally breathe for a little while and maybe take in more air, because the CPAP machine's not helping me at the moment, and like I can't breathe. It's weird. And
yeah, well, maybe we can talk offline and work on that a little bit.
We will talk offline. I have an
Yeah.
appointment in October.
I really appreciate you sharing that with the group, Evelyn.
Yeah, it's like someone else said in chat, I really cannot sleep without it.
Yeah. And I'm curious to hear from Wendy as well about your adaptation to CPAP. And I see Darlene had a question. I do agree, I do think that there is culturally a greater awareness about the importance of sleep, and maybe there's a greater awareness about some of these sleep conditions like sleep apnea. I think it would be great if our organization advertised and drummed up business. I know Karina and I were talking about before the lecture started, one of the difficulties of living on the peninsula is just access to healthcare. So I know it can be hard sometimes to get a referral and get in. Unfortunately, our lab is the only lab in Clallam County right now, but there is also a sleep lab in Jefferson County, and I believe in Silverdale as well. Yes. Any other thoughts? Well, I have to say, talking with you guys has been the most fun part of this whole experience. I appreciate you being here and listening to me. Yeah, it's just nice to connect with the community.
And thank you for being here with us, Claire. This was a wealth of information, and I appreciate so much that you came to share this with us. And I particularly love your slide about taking action and all those things that we can have a little say in how we're approaching sleep every night. Particularly, don't watch the clock. When I have experienced some sleepless times, I've definitely been the person there looking at the clock, crunching the numbers. Okay, if I fall asleep within the next, and that doesn't help anything. I finally learned to stop doing that. So thank you so much. Does anyone have any final questions? Don't want to cut anyone short. All right. Well, we can move on. Thanks to all of you for joining us. We'll move on to our little wrap up, and let's see. Claire, can I share my screen? Do you mind ending your screen share if you're
Yeah.
done? Did you have any more? I'm so
No,
thrilled
that's
that
it.
you went into our collection. No one's ever done that before. That's so great. And you and I had an overlap. I pulled some out of our collection too. So I'm very excited. We had one title in common. So thank you to Claire. Thank you to everyone. As I said, we have some resources here if you want to explore further. I have a few links to online resources, and then 4 titles that I pulled from our collection. And as usual, I will compile Claire's resources and my resources with hyperlinks in the big resources email that I will send you all next week, along with a link to the recording. And then next month, July 18th, our topic is going to be synonyms for grief. And we are going to explore how creative writing can be used to cope with loss. So Anne Marie Wells, who is a poet, an author, and a teacher, is going to join us. She recently published a memoir in verse that was inspired by the loss of her father. And she's going to take us through how we can transform past hurts into creative works. So I'm really excited to see what she has to share with us. Her presentation helps to create a cathartic outlet, and which I think we all have a need for from time to time. So I hope that you'll all be able to join us for that. But that is it for today's program. So thanks again to Claire for joining us and sharing all her knowledge. And thanks to all of you for your interest in living well as you age. Take care, everyone, and I will see you in July.
Thank you.
Thank you.